Okay, well, we have already over 108 participants. There will probably be some more people who will be joining, so you hear all the beeps. Anyway, I wanted to get started also because I didn't want to wait too long to hear. This is basically the first kind of real formal start of our event series for HCRI. This is a series that Jessica Murphy, who you all know, and I run together, and is usually shared by other academics depending on the theme. We're going to have a whole bunch of events coming up in the next few weeks in term. We're going to hear about UK Med. We're going to hear about human rights defenders in Russia, about Srebrenica. There's a whole lot of other things coming up. Anyway, if you are signing up for events, please do that through Eventbrite. You will notice sometimes that you may not receive the link. What happens a lot is when we send a Zoom link through Eventbrite is that it ends up in people's spam boxes. So if you can't find the Zoom link on the day of the event, then please check your spam box first to see if it's there. Okay, I also had to say, Dan asked me to tell you all, at least the PGT students, the postgrads, that we know that there's a social event after this. It has been rescheduled to start taking place as soon as this finishes. So you don't have to worry about like having to leave and missing out. Okay, so this is going to be our landmark lecture. This is the biggest event that we have in every term. We try to invite somebody who is a prestigious name in the field. I will let Stephanie Sodero explain why that is. Not want to take away from that. So the rules on Zoom are simple. If you're not speaking, please keep your microphone off. Be nice if you want to write something in the chat to people. Questions that you have, we're going to have a special question and answer session after this. So first, Stephanie and Omar are going to talk a little bit together, and then we're going to have Q&A. If you have a question, you can either write down your name and you will be then called upon to give that question, or you can write out the question as it is, and then Stephanie will just read it up. Okay, well, I think I said all the things I need to say, except for one, which is that we are recording. We're doing that because there are people who can't join us right now, but are very keen on hearing it. So just keep that into account. This is recorded. And then we will make, of course, this recording available. So, okay, I think I've done all the household things. I'm really pleased you're all here. Great for joining in. I hope it's going to be an awesome start to a nice event series this year. So, well, I'm just going to hand it off to you, over to you, Stephanie, to kind of introduce yourself a little bit, Stephanie Sodero, our newest addition, and to introduce Omar. Okay, good luck.
Thanks, Sophie, and great to see so many people here. My name is Stephanie Sodero. I am a lecturer in responses to climate crises at HCRI. In my own research, I look at how global medical supply chains are impacted by a changing climate through severe weather events such as floods and hurricanes. And given my interest in medical mobilities, I am very happy to be here talking with Omar today about his work on wounds and specifically how wounds travel. When Omar talks about wounds, he's talking about physical wounds, but also about social, economic, environmental, and other types of wounds. Omar is the author of Ungovernable Life, a book that tells the story about the rise of healthcare, national healthcare in Iraq over the past century, and the devastating wounds to that healthcare system as the result of decades of conflict. Omar, a very warm welcome to HCRI's landmark lecture. We are very happy to have you with us.
I'm happy to be here.
My first question for you is about your own journeys, your journey from Iraq to New York, and your journey from the field of medicine to the field of anthropology. Tell us.
Right. Thank you so much for this invitation. I'm very honored and really humbled by this invitation. Thanks to Sophie, Jessica, and to you, Stephanie, for organizing this and carrying out this over the past month of preparation and working together on preparing this event. So let me kind of give you also, through this kind of personal story, I usually start to open up questions about the broader research that I do. So I grew up in Iraq and came of age in the 1980s during the Iran-Iraq War, a period that was pretty particular in the history of the country. And also at the same time, I think it's in terms of global history. The Iraq-Iran War was probably one of the last nation states war that we witnessed in the 20th century. And it's actually the longest conventional war of that century, of the 20th century. It's not very often understood, partly because of the obscurity of reporting about that war and state propaganda that often controlled what was going on inside Iraq or inside Iran. So you can imagine that was kind of the period of my coming of age in a state that was that at one side was there was a kind of a very brutal authoritarian regime that governed the country, but at the same time a very well developed state because of the social welfare, because of the kind of very advanced infrastructure in terms of healthcare and urban development and all of that. In 1990, with the aftermath of the first Gulf War, that was kind of also my last year of high school, and I was getting ready to enter college, and a lot of my studies were interrupted by the first Gulf War in 1990. And eventually I entered medical school and did my medical training in Iraq's main national medical school, the Baghdad College of Medicine, in the 1990s. And this kind of coincided with a period of sanctions, which kind of followed from the bombing campaign that destroyed Iraq's healthcare infrastructure, communication, sanitation, transport. After these 40-day bombing of the country, a lot of the country's main basic infrastructure was destroyed. So my medical training in Baghdad University and Medical College really coincided with that period, and it in time throughout that few years within the 1990s, my experience as a physician and as an Iraqi was definitely shaped by this the really kind of slow deterioration of the country's healthcare in general and health status. So during the sanctions, people can just to give a little bit of an overview of that. The Iraq invaded Kuwait in 1990s, and the U.S. Supported by an international coalition tried to got Iraq to pushed the army out of Kuwait, but in that process destroyed the infrastructure of the country. At the same time, the economic sanctions, that is considered one of the most comprehensive and harshest sanctions ever been imposed on a country in the past 100 years, were very devastating at the population level. And this is something that I witnessed and experienced as a physician, being trained in a hospital where medical supplies and medical like sanitation supplies, like IV fluids, drugs, medication, chemotherapies, antibiotics, were all being monitored, and there was a lack of that supplies in everyday practice as a physician. So while we are trained in this kind of universal textbooks of medicine in general, the realities of everyday life as a doctor really reflected something completely different. It reflected also a more improvised practice in terms of medicine, and also reflected the kind of the deterioration of infection control, salaries for healthcare professionals, and also the rise of a lot of health problems emerging during this period. So just to give you a little bit of statistics, infant mortality, maternal mortality, they all doubled during the 1990s, and there is a plethora of literature that has explored the impact of the sanctions on Iraqi population, causing hundreds of thousands of deaths of children, of vulnerable population in general. So this was the kind of the backdrop of my medical training in Iraq. And in the 1998, I actually left Iraq, escaped from the country in 1998, smuggled into Jordan, and eventually ended up in Beirut, where I also practiced medicine for a year in an emergency setting. Worked as an emergency medicine doctor, and then eventually did a degree in public health at the American University of Beirut, where eventually I also got a scholarship to go to study in the United States. And I ended up at Harvard University doing a PhD in anthropology. At that time, I really didn't know a lot about anthropology. It was something that I worked on in Beirut, working with a wonderful medical anthropologist, Professor Cynthia Minty, who was one of my first mentors. And I ended up in the US really in August 2001, 1 month before 9/11. And that also shaped eventually my own mobility and my travels, and my possibility to do the kind of research that I was doing. I ended up really stuck in the United States for 4 years, not being able to leave the country, fearing that I will not be let back in. But I eventually left to conduct my research, which basically I did a historical archival work on the history of Britain's involvement in Iraq in the early 20th century. And I also conducted a year-long study. Actually, it lasted more than a year, but I interviewed Iraqi physicians who are just like me, had escaped Iraq, but they've ended up in the British National Health Service, and they were trying to be integrated as overseas doctors in a system that historically they saw as an extension of their medical training. And through the kind of the stories that I told in the book, I showed how this kind of colonial patronage, or this colonial history shapes the movement and mobilities of these doctors and their quest to try to end up in the NHS system to find work, find a better life, and through the stories of these doctors and their training over the past 100 years and their exodus from Iraq during that moment, I tried to capture what I called like the human infrastructure, the unmaking of the human infrastructure, looking at doctors specifically as an infrastructure, as a kind of an important connection between the country's more material infrastructure and state building project and the everyday life of populations and their health. And so this was kind of the story of my kind of studies. And eventually I ended up back in Beirut for the last 7 years before I moved back to the US in 2018. That was my first job at the American University. I worked at the School of Public Health, and I was teaching anthropology, social medicine, and global health to medical students, public health students, and social science students. Eventually, in 2018, I ended up coming back to the US, where I took a job at Rutgers University, and as they say, the rest is history.
And here you are now with us. That is an incredible journey, academically, professionally, personally. Studying medicine during conflict would provide a very particular perspective and perhaps lends insight to your focus on wounds. You're interested in the biosocial life of wounds. I have a three-part question. The first is, what do you mean by biosocial? Second, in what ways are wounds biosocial? And third, how does this relate to conflict and humanitarian response? So the first part again is, what do you mean by biosocial?
So yes, biosocial. I mean, in many ways, the biosocial embodies also my own training. I've been trained to look at wounds from more of a medical and a biological perspective. So inspecting wounds would mean that I would be trying to describe that wound, figuring out what are the damages that happened in the body. I would have to take a swab, send it to the lab, figure out if this wound is infected, how things are affected more on the structural level. That biological story has a biography in many ways. That biography of that wound is something that is very also very social, specifically with the wounds that I was trying to examine that are really war-related, conflict-related injuries and wounds. These injuries happened in a specific event, usually. So in Iraq there was really a lot of cases of people being injured in suicide bombing, people injured in the aerial bombardments of the U.S. occupation forces or in counterinsurgency operations, or through kind of the civil conflict that emerged, the violent conflict that emerged in Iraq after the occupation in 2006 and 2003, and then kind of the civil war 2006, 2007. So it felt to me that the biological questions of the wound cannot be reduced merely to the medical storyline of that wound. It needed to really incorporate a broader personal, broader social aspects. And many times, some of these wounds that I saw were collective in the sense that members of the same family were injured all together in the same wounding event. So the biosocial life of wound really attempts to bring in both a sociological treatment of wounds, and of course the idea not only of injury but also caring for that wound. The quest for treatment is definitely shaped by social realities of the populations that I was looking at and by the individuals and the communities have been affected by this. So trying to marry or look at the entanglement of the biological story and the social articulations was very much a way to holistically look at questions of injury and pain and suffering, not only through looking at the broader meaning and how people interpret these injuries, but actually through telling the story of what happens to these wounds, because in many ways they did have a very different trajectory than, let's say, a wound happening, let's say, in London or in another city where maybe there isn't a conflict. So a lot of what the wounds that I was looking at depended a lot on the experiences of the persons that I was trying to interview. So that's the biosocial. What was the second part?
I feel like you got all three in one go there. The second part was, in what ways are wounds biosocial? And
Right.
then the third is, how does this relate to conflict and humanitarian response? So perhaps you could focus on that last one a bit.
Right, right. So the thing that also define these events, these wounding events, is that you are dealing with injuries of a large number of the population. These are usually war wounds are often treated in, I mean, historically speaking, when we speak about war wounds, we're talking about specifically military medicine, we are specifically addressing wounds that often happen at the war fronts. But with the transformation of the nature of war and the kind of war on terror, period that the Middle East has gone through, we see war happening at the urban centers, at rural areas. Is not anymore a kind of a clear line of where this war is being waged. And in many ways, wounds happening in these kind of settings represent a very challenging problem to medical healthcare systems and to humanitarian responses. For medical healthcare systems, usually neither the doctors or the healthcare systems are prepared to deal with kind of massive numbers of injuries, influxes of people coming in after a suicide bombing, things that kind of were punctuating everyday life in Iraq. Sometimes there is a suicide bomb every day. So imagine the flux of patients coming into the emergency room, trying to deal with this large number in a broken down healthcare system. So these wounds represented a very challenging problem to the healthcare system. And in terms of the humanitarian response, there has been a lot of interesting work happening in conflict zone, and I think maybe Doctors Without Borders (MSF) has dealt a lot with dealing with conflicts. But I feel at least my experience and my public health work in the Middle East, and I worked very closely with different groups of MSF. The scale of injuries and the difficulties faced to respond to those has been a very big challenge to the humanitarian landscape and humanitarian interventions.
Thank you. Your description of like a ubiquitous war front that crosses urban and rural areas, as well as the idea of floods of patients overwhelming hospitals that have deteriorating capacities. That leads me to my next question, which is about mobility. In broad social science terms, mobility refers to the movements as well as blockages, critically, immobilities of people, goods, services, information, ecologies, and more that constitute everyday life. From everything from like how a child walks to school to mass migrations of entire communities across national borders. From your perspective as an anthropologist, how is a mobility frame useful in thinking about wounds and how wounds are mobile? Yeah, that's my question.
Right.
Yeah.
I mean, we are all mobile by default, I guess in the sense that even if we are limited with mobility, we seek that idea of movement and trying to be free, at least in our own movements. So one aspect of mobility in a more kind of broader philosophical or existential kind of case is that it's a kind of a condition of our existence in many ways. It's something that it's not that it's just a topic that one needs to understand and study, but it is almost, as you said, it's a framework. It's almost a methodology to examine how people go about dealing with their everyday life, going to work, going to school, or go to the hospital. And that element was drastically impacted in Iraq after the 2003 US occupation. And this is partly because of the violence that erupted because of the occupation, and also the insurgency and the counterinsurgency, and eventually the sectarian killings that happened, started kind of happening in Iraq in 2006, 2007. So for a while, mobility became something very contested in a place like Iraq, because people were afraid to leave the house to go to work. People started shifting their own jobs from areas that they were be kind of, seen as members of the other sect, so they would be killed if they go to that area. So a lot of transformations were happening around cities like Baghdad and other cities in the country around this. So that's one element of mobility that became very interesting to me, to think about how we need to understand how patients and people's life has changed around the movements. And of course, when I am speaking about a wound here, at least in this context, the sectarian tensions that emerged in Iraq are themselves as a certain kind of wound. It's something that emerged in relationship to the past few decades of war. It's not necessarily something that existed before, and suddenly, maybe there were tensions in the history of Iraq, but nothing to that extent that happened after 2003. So that itself is a social wound that until now I think Iraqis are trying to deal with. And I think one of the testimonies that it was responded to is that period of violence, at least at the sectarian level, ended very quickly. But it still continues to shape the country, but partly because of the broader political structure of the government that was installed after 2003. The sectarian political system in the country does not necessarily represent the social realities of these different groups in Iraq. The other kind of element of mobility, which I really was that pushed me to think about this problem, is when I moved to Beirut in 2011, I started witnessing and seeing a lot of patients from Iraq coming to Beirut to seek healthcare in Beirut's kind of flourishing private healthcare landscape. And in the beginning, I kind of like, a lot of people thought that these were just like what you'd call medical tourists. People come in to seek healthcare in a better healthcare system just because they can afford it. But that was not the case. A lot of the patients I saw were coming from lower middle class, working class, but some of them had sold a lot of their belongings just for the sake of bringing a member of the family to Beirut to have a better prospects and prognosis for treatment. So this really intrigued me. I've already done a study on doctors moving, and it became kind of clear to me that the other side of the story would be looking at the patients. So I began really interest in documenting this mobility and immobility of these wounds, because one of the stories that I confronted were that patients couldn't, let's say someone got injured in the province of Anbar, which is in the west of Iraq. It was much easier for them to travel to Jordan and cross the border to Jordan than go to Baghdad in 2006, 2007, because of the fear of sectarian killings or assassinations or suicide bombing. So the whole landscape of how people seek healthcare began to transform. And for me, this was a useful analytic. Mobility became a useful analytic to tell the story of the broken down healthcare system in Lebanon, in Iraq, and its kind of the manifestations of this kind of therapeutic economy that was emerging in places like Beirut, like in Delhi, in India, in Iran, in Jordan, and even in Syria prior to the Syrian war. So this is all happening after 2003, before 2011, and even after 2011, a lot of Iraqis prefer to go to Syria sometimes to get treatment than to stay in Iraq, partly because of the really severe deterioration of the country's healthcare system and the inability of this corrupt government that runs the country to rebuild what has been destroyed over the past decades.
Thank you. I want to revisit this medical tourism writ broadly to Beirut, but first I want to ask you about therapeutic geographies. You use historical and ethnographic research methods to gain insights into the intersections of war, trauma, and displacement. You write that in Iraq, Syria, Lebanon, Yemen, and Libya, that, quote, war injury has become endemic, shaping the everyday life of the injured and their families. I'm going to repeat that because it's so important. War injury has become endemic, shaping the everyday life of the injured and their families. In your research, you work with therapeutic geographies. First, what does this term mean to you, therapeutic geographies? And second, what does your research tell us about the changing therapeutic geographies of medical and humanitarian care?
Thank you. So therapeutic geography was a kind of a useful analytic that I wrote about with other colleagues. And actually, what that paper that we did was published in the Lancet, and was part of a series on healthcare in the Arab world. And ironically, this was the only piece on conflict, because at that time, this was like early 2011, when this was prepared, and I think it was published 2013 or 14. I forgot the year, but at that time, no one was really trying to look at what the conflicts in the region had done to health systems and healthcare systems. The conventional public health and global health framework in understanding healthcare systems is to take national borders as the boundaries for understanding what is a health system. So, and of course, the humanitarian sector usually defines their kind of health system or healthcare within what we can consider as refugee camps. And again, these are defined spaces that people have been using to kind of talk about healthcare, talk about the impact. What the anthropologist kind of came to show, at least through the ethnographic field work, was that we cannot really take on these kind of preset borders and an idea of a national health system without looking at how people and populations are moving to seek healthcare. So if you look at the Iraqi case, thousands of patients leave the country every year, and they travel to, as I kind of previously said, to India, to Iran, to Turkey, to Syria, or to Jordan, or to Lebanon. And so there is a pattern of mobility and of movement of patients that needed to be counted for when we are speaking about health systems. And the relations and overlap between these different health systems was very, very important to also highlight. So that was kind of one of the main reasons why we wrote this piece, that began to just ask questions around reorienting our gaze on these health systems, and through these kind of more policy, broader global health and public health frameworks, to say we need to look at how conflicts are changing the movement, and in turn changing the landscape of healthcare. So Beirut, when it becomes a center for Iraqi healthcare mobility or treatment of these patients, there is a whole political economy, there is a whole therapeutic economy, there is a whole touristic economy that emerges in these places. And in many ways, actually, the story that I would like to also tell over for my research is how these two healthcare systems have been kind of interacting through this period, and this is mainly hospitals like the American University of Beirut Hospital actually depended on Iraqi patients for a really long time, from 2007 when the borders and it became easier for Iraqis to travel to Lebanon, until very recently. I mean, before the kind of the last couple of years, and maybe even right now, there are patients coming in. I haven't followed things, but what you see is you see a kind of a movement of patients between two healthcare systems that needs to be understood also if you want to do a kind of a health system analysis. It also opens up this idea that one needs to look at the regional perspective and not only the national perspective when you are trying to address some of these problems of humanitarian relief or seeking healthcare in general. So that was kind of one of the reasons this idea of therapeutic geography was very useful in thinking about the pre-existing models of and framing of healthcare.
That certainly resonates with my own work on transnational medical supply chains. Mm-hmm. The national lens doesn't do the trick.
Right.
So in your book, following from what you just said, in your book, Ungovernable Life, you start by describing a street scene in the Hamra district in Beirut, Lebanon. And I'm actually going to read to you your own work. So you describe your ethnographic fieldwork. It's a short paragraph. You say, over the course of my daily wanderings, I have been accustomed to encountering scores of Iraqi patients and their escorts. On one of Hamra's sidewalk benches, there's a group of middle-aged Iraqi men chatting about lab results. On another sidewalk, a woman wearing a traditional Iraqi cloak is pacing with her sick child. Farther up the street, near Starbucks, of course, there's a couple of older men dressed in customary robes unique to the south of Iraq, and they are asking for directions to one of the hospitals, and it goes on. So there's very much a sense, you paint a picture that the Hamra district in Beirut is, in a way, a hospital, a medical care center for Iraqis. Given this, what are the larger societal implications of wounds traveling for the Iraqi healthcare system and for the Lebanese healthcare system and beyond?
Yes. So one of the main kind of problems that emerged around this issue, so if we look at both the healthcare systems, is that with the failure of reconstruction and repair of the healthcare system, the Iraqi government began to rely on this therapeutic travel. So when I was saying that people would be selling their belongings and try to, eventually the Iraqi government picked up on this process, and they began to actually fund people who they saw as kind of deserving of government support. Many of them actually fighters, police officers, kind of people who had connections with the militias and political parties. They were sending them to Beirut and paying for their treatment abroad. And so for that decade, you had millions of dollars have been spent on paying patients and their escorts to travel and get healthcare from outside of Iraq. And what that meant, that basically there was less investment in repairing the local system. And of course, this also, it's almost like the Iraqi government is admitting that it is kind of, that its healthcare system is unworthy of investment. But, you know, there's a lot of complicated issues. Paying people to do this was an easier way to also stifle money, because there's a lot of corruption that goes into these paying people to to get treatment abroad. So, and this was kind of the classic story of Iraq is that, you know, every time there is a kind of an interesting project, you realize someone has figured out a way to cannibalize it. So in one way, you get the investment in decentering or in outsourcing national healthcare to a regional healthcare system. And from the other side, from the Lebanese side, you get a kind of a very strong welcome to the movement of patient, because this is a lot of these cases were being paid cash. You know, there was no health insurance to run after to pay for these patients. So it created an incredible economy around the Iraqi patients, and hospitals and Lebanese doctors were racing to figure out a way to bring more Iraqi patients. And actually there were this network of middlemen and middle persons who were always taking some percentages from patients who are coming in. So for example, there are these middlemen who would go to a hospital in Lebanon and convince them that, you know, they will bring them, you know, 20 Iraqi patients a month, and they will get a percentage on these numbers. So there was a whole system, I would say a very corrupt system and an informal economy that emerged around the movement of patients. And in many ways, for a long time, even at the American University Hospital, they depended and they kind of built their whole system around developing the center as a regional healthcare center, and mainly thanks to the higher number of Iraqi patients. This system all collapsed at some point in 2000 and I think 2014. This is all in response to the ISIS war, when the Iraqi government actually didn't have any more money. All the money that was being paid to send the patients began to be channeled to the war after the takeover of Mosul. So in many ways, healthcare system in Lebanon also struggled very badly during that period because of the shortage of Iraqi patients. So it's a complex story in terms of healthcare systems, in terms of war, in terms of the movement of the patients, and that I've been really being part of myself as someone who was working in the university, but also someone who's documenting what's going on and working with a lot of international and local organizations to respond to this.
That's fascinating. Thank you, Omar. I expect we'll have some questions on this big business of healthcare. I'm going to shift a bit right now. Too often, when we think of wounds, we think of physical wounds. Can you tell us about the biosocial life of mental and emotional wounds, mental health? For example, you have done work on everyday survival strategies of communities, families, and individuals impacted by war and displacement. How do mental and emotional wounds figure in this research?
Right. So I've written a piece which actually carries the title of this talk, When Wounds Travel. And that was kind of my first big anthropology piece. And what I tried to capture is the story, and this is kind of happening, the storyline is happening before the Syria war in Lebanon. And so this is when 2006, 2007 unfolded in the region. And there were many people escaping from Iraq. And Iraq was the biggest kind of humanitarian crisis just before the Syrian war begins. And this mobilized, I mean, it's kind of people have to recognize that it is that 2003 and its aftermath that began mobilizing a lot of the humanitarian organizations into the region. Prior to that, you didn't have that much work, but the Iraqi displacement and eventually the Syrian displacement really shaped the new humanitarian landscape and how it transformed. So, and of course, if we think about the humanitarian landscape, a lot of that work on conflict has happened in sub-Saharan Africa or in African states, where the landscape itself and the of healthcare completely is completely different. When the humanitarian organizations moved to the Middle East to deal with that, the only knowledge they had was and the experience of dealing with kind of low resource settings in many of the African states that they worked in. So there was a kind of a learning curve that needed to happen, partly because, let's say, Iraq and Syria had a more advanced healthcare system. They had large number of doctors. So the humanitarian organization confronted a big dilemma. How do you intervene in a place where there are a lot of doctors? How do you intervene in a place where the problem is the destruction of healthcare, but not necessarily the lack of physicians? And actually, many of the local physicians knew much more than the young, energized, rebellious physicians coming from Italy and from Greece and from England and from Western countries. They were not as trained in conflict as the local doctors. So there was a big dilemma on how to really respond to that. So this is kind of part of the story that I was interested in. Now this is all like what do you call it, an introduction to this notion of the mental health wound. And so in many ways, a lot of these humanitarian organizations and international organizations were beginning to try to manage and mitigate this problem by either providing aid or by supporting resettlement of displaced and the refugees from there to the West. So there was another kind of economy that emerged there, a therapeutic economy, or what you would call a resettlement economy, where patients needed to be identified as vulnerable, as precarious, as traumatized, to be able to get the right reports, to be sent or resettled abroad. So suddenly the language of mental health and language of trauma and the experience of trauma became so central in how people presented themselves and how people even performed certain notions of vulnerability, precarity, or the kind of the need for being resettled. Not necessarily saying they were faking it, but that became the center for any kind of assessment that comes from of these humanitarian organizations. So I wrote about a story that an Iraqi a man who moves to Beirut after all of members of his family gets killed by one of the local militias, and he was tortured, and all the members of his family were killed in front of his eyes and also recorded on a video. And so he carried this video with him, and he worked in a small local communist bar in Beirut. Although he was not necessarily communist, but he just the people in the bar felt very empathetic. They welcomed him. They tried to help, and the members of the bar were Armenians, and they've historically moved to Lebanon because of the history of the genocides in Turkey. And at the same time, he settled in. He was living in the one of the Palestinian camps, which became like kind of an urban ghetto where a lot of displaced people, refugees, were settling there. And he was dealing also with the Lebanese population themselves. Have kind of had this history of civil war, of different kind of wounds and injuries that had shaped that place. So I was really interested in how social wounds become layered over each other and become transient also in a place like Beirut. And in this piece, what I tried to really capture is how this kind of invocation of your own wound brings up other wounds and amongst others. And I was trying to look at what I called the interstitial, like wounds as the kind of the interstitial tissue that brings people together, but then also it is what separates them. So I was dealing with, I mean, here wound as a social wound, we can think about it as a grievance, you know, certain kind of grievances that have shaped your own life trajectory, and the collective grievance that you and other members of a group maybe share. And what happens when they confront other kinds of grievances. And so this was the kind of the landscape that I was trying to explore by looking at places, by looking at the urban environment, by looking at social interaction, social relations. And what really fascinated me is that at that moment of acknowledging this guy's wound by the humanitarian organizations had to be kind of understood through this framework of trauma and PTSD and all of that. So I was trying to show that rather than taking on this narrative of PTSD and trauma, which is really very limited in many ways to understand the complexities of these injuries and the social fabric that has been impacted by different histories and different populations all over the same place, that it actually created more and more problems. I mean, maybe we can call it an unintended consequence of these diagnostics that someone like this guy Hussein, who I speak about in the piece. In the beginning, his wounds become very empathetic, or people feel empathy towards it, and they hire him and they try to help him. But in time, you realize his obsession with showing his injuries to the clients who come to the shop, his constant kind of retelling of his story, which is something he also had to memorize and perform well for the international organizations for the sake of him being resettled. And eventually he did get resettled. I don't know where, because as I tell in the story, he suddenly disappears from the scene, and I come back to try to look for him. I can't find him. So it kind of also helped me to think a little bit about the transient element of these wounds, how people come into places and then leave, they come back maybe. So I was really trying to give a more dynamic landscape and of the relations and of these grievances that I believe felt very useful and productive to understand both how projects of care and the wounding are kind of entangled with each other. So you know, the wound could invoke care, but it also could invoke tension and conflict, and I think this is maybe in a broader way, this could be a useful framework to think about other places too. I think we especially in this present day and moment where there's so much tension, there's so much inability to speak. Everyone is singing out their wounds without really listening to the others, and I feel like it might be a more useful way to begin to see the overlaps and the similarities of that of these different wounds at this point.
Thank you, Omar. One last question, with just a few minutes to answer this question. We started this conversation with your story of moving from Iraq to the US eventually. Can you tell us about your most recent journey back to Iraq, and particularly your research on the Arab Spring as experienced in Iraq?
Yes, I'm just beginning this, and I think I have been dealing more with the emotional kind of side of this, but I'm beginning to write about it too. I visited Iraq several times during the past decades, but I haven't kind of been back to Baghdad, the city that I grew up in, for over 22 years. And in 2019, in December 2019, I made that big move to return back to Iraq for the first time in decades. And I was carried back by a really an energy of the uprising that I saw unfolding while I was sitting in my apartment here in New York, and looking at how these incredible young men and women who really confronted this corrupt and horrifying regime that runs the country, really not fearing death. Until now, and this is something hasn't been covered very well. I mean, hasn't been covered in general in Western media, but right now, close to more than actually 800 people have been killed since the beginning of the uprising in 2019. About 5,000 people have been injured. Almost 2,000, 3,000 have been permanently disabled, or disabled more in a permanently during this time. And now also there is another trigger over the anniversary of the uprising. There is a new ignition that people now are out in the street demanding transformation of the political system. So my return, I spent almost a week in Tahrir Square in Baghdad, and the picture actually behind me, the one that used by your institute, is definitely one of the pictures I took from what the Turkish restaurant, this empty building that became iconic for during the uprising, because the people occupied it and really wouldn't leave the building for months and months. And so I really spent time in Tahrir, just trying to understand why people have been mobilized. How are they mobilized? And what I realized, there was an incredible stories of different kind of wounds, also grievances. Some of these kids, their fathers have been killed by the sectarian violence, or their brothers, and some of the friends that I saw, for example, there was someone's father who was killed by, let's say, by the Sunni extremists, and the other guy's uncle has been killed by Shia extremists. But they were all kind of together, realizing that one needs to overcome these tensions, and this was kind of pretty inspiring, not only for me, but to also a lot of Iraqis in the diaspora. For once, since the occupation, we felt that there was something really big happening in Iraq, a new kind of political consciousness emerging from this uprising, shaping how people relate to the country, shaping how people relate to religion, shaping how people relate to their future. And I've been trying to think about this through the kind of what sociologist Amir Durkheim would call the collective effervescence. How is this effervescence has been shaped by this energy? How do people kind of move? And something that I really felt, and that kind of propelled me to go back and to overcome my own kind of wounds of dealing with a place that I've had a lot of mixed grievances about, growing up there, and feeling kind of the loss of a place that I still have trouble calling home.
Thank you, Omar. We're going to end the first part of our landmark lecture there. You have given us a lot to think about, and thank you so much for being so generous, both with your personal experiences and your professional experiences. We are going to take a 5-minute break so everyone can get tea and a snack, and come back for questions from the audience. Thank you again, Omar.
Thank you.
Gallery view. So I think we'll start coming back if people want to turn on screens, audio. If you want to ask a question, please write it in the chat box, or if you want to ask the question, and I will read it out loud, but if you want to ask the question yourself, just type your name in the chat box and I will call on you to unmute yourself. All right. All right, Omar, are you ready for some questions?
Sure.
All right, here we go. So Bruce Stanley asks, he says, conflict logic often means making wounding the other even more terrifying and damaging, using the wounding as a claiming of the body of the enemy. Israeli use of spinning bullets against Great March of Return, new US drones with spinning knives. Why the move toward extreme wounding?
Yes, so this is a brilliant question, and I see also Bruce ask another comment about novel Frankenstein in Baghdad. So actually, I've written a piece called "The Wounds of Baghdad's Frankenstein," where I reviewed that specific novel, and it is something that has been very central to my thinking about the social wounds and these kind of layers of wounds that do not heal. So I can maybe I can try to find it and put it in the chat box. But if you Google Frankenstein wounds of Baghdad, you probably can find it online. It's in I think in Open Democracy. But anyway, so the why wound, why not kill? I mean, so the idea here is really, if you think about war and conflicts, that the kind of the main logic and the main purpose of war is to wound and outwound your enemy. And in many ways, that is something maybe we kind of all agree on. I think the move from killing to wounding represents a kind of a very dangerous turn, and I think there are many people who have been writing about this process, specifically in the context of Israel-Palestine and in the context of the US-led war on terror. One thing that I can kind of maybe contribute to is to say that actually being wounded in a place like Iraq or in Palestine, that means the mobilization of the entire collective body, of the family, of the relatives, to try to care for that wound. And that actually, in many ways, not only deals with just like getting rid of one person, but that actually creates a kind of a therapeutic or a kind of a care community that becomes more debilitated because of the dealing with the wounds of someone in the family. And one could really think about this as a form of politics of trying to injure and out injure. And it's very important to understand that, you know, this person is alive now, is still alive, the person who is wounded, but then requires so much care, so much you know, treatment, that also you're dealing in contexts where healthcare situation is completely debilitated by the conflict, let's say in Gaza or in Mosul or even in Baghdad. So you get the mobilization of the entire family to deal with this rather than you know, just a single death in the family that maybe people become angry about, or so it really it's a distraction, I think, and it's also burdening the society with this long-term impact of the high number of wounded. And this is what I was saying, that wounds are, you know, and I use it in scare quotes, that it's an endemic problem because of the high number of people in these communities who are injured, and and there's a lot of people are trying to take care of them.
Thank you, Omar.
That's a kind of the more social take on this, rather than going into more broader abstract political critique.
Omar, did you want to speak to extreme wounding specifically, or the use of these different technologies? Or
really, I'm not 100% sure how to really. I mean, I think yeah, there are really cruel technologies. I think there's a lot of experimentation that is happening, and with these weaponries, and I feel like I really don't have a lot to say about it, apart from being very disturbed, I guess.
Thank you. Osama Tanous asks, was there any model for collective dealing with trauma rather than individualized or medicalized dealing?
Right. Well, I mean, the to start with, in a place like Iraq, the individualized problem is already not a thing, because of the collapse of the system itself. So the management itself is not necessarily proper in the way we understand it as a medical professionals, but I would say that a lot of there wasn't really a kind of a formal system to respond to these traumas. But in Iraq, if you kind of follow the story of let's say a suicide bombing in a market, what you see is that after the bomb, people will run towards the injured. I mean, no one is waiting for, let's say, the first aids or the first responders. This really is not an issue. People come in with their own cars, with their own taxis, pickup trucks, and begin to put patients in the back of the cars and drive them to the closest hospital. So the collective model is something that is emergent, constantly happening in many places, and people, I think, got used to dealing with that. And that's kind of something you see also in Yemen, you see in many of these contexts, that people begin to move towards the bomb, towards the explosion. When you see a bomb happening in a Western country, everyone is fleeing the scene, and just like you get your police and your first responders coming in places like Iraq, because of that lack of these first responders, or the delays, and also the scale of these bombings are very, very big. So people themselves become the first responders. And this has kind of partly is something really very endearing to see, because you see people rushing towards the bomb to save others. And this is why, let's say, both terrorist organizations and the United States both use this to have more damage and more extreme damage. So in suicide bombings, you get that people will there is a detonation of the first bomb, and then when people come in to rescue, there is another bomb that explodes. In military lingo in the United States, it's called double tap, or double tap bombing, or something like that. It has a very technical term, and that basically means you bomb, and then people come in to rescue, and then you do your second bomb. You create a broader damage in terms of life and casualties. So these technologies of bombings, and maybe these are some of these extreme, I mean, not only in terms of the technology of the wounding material, but also in the practice itself, became very common and used by all of the sides of these of the war on terror projects. So this is something that also, while we see people coming in and then moving people into the emergency room, this also means that all of this process of triage is shaped by a very much of a social process of people trying to help and moving patients into the emergency room. And this kind of had been also seen as one of the reasons why some of the hospitals and the emergency rooms become a big problem in terms of being contaminated with heavy metals, with bacteria, because the process, the triage process, is not really a kind of a sanitized one. And it's definitely more of a social form, based on a social model, rather than a kind of a medical one where, you know, patient comes in and you get the nursing kind of taking that person and cleaning the wound and so that doesn't really happen. If you look at an emergency room in Iraq after a bombing, it's a big chaos. And I'm sure this is also, you know, Sama is a good friend, so he knows probably in Gaza and in other places that also been probably the case when, you know, you don't have enough staff to deal with this problem.
Thank you. The image of people running towards a bombing is very powerful.
Right.
Jess Baker asks, issues regarding refugee status and individuals seeking asylum are more prevalent now than ever, particularly with the hostile environment policies in the UK. For those who do not have concrete evidence of trauma, such as the video you mentioned earlier, what support is available on the ground for those who opt to seek asylum in the UK and Europe? How can this continuation of support for mental and emotional wounds be ensured throughout the migration process? Thank you.
Yeah, very good question. The problem is, it's this, again, to use the same word I used before, it's a triage process. Accepting refugees to come into countries, it's a triage process. It means that basically people go and decide on if you are worthy of being resettled somewhere else, and if you are deserving as a refugee or a displaced person to receive healthcare or receive a kind of a better life for yourself or your kids in the future. While the kind of the story has a certain kind of echo from Europe, because of the recent kind of movement of hundreds of thousands of refugees towards Europe and taking on very difficult and dangerous journeys to get to the other side of the Mediterranean. There are millions of displaced who continue to live and survive in, either internally in their own countries or externally in regional countries across the region. And while there has been attempts by the humanitarian organizations to deal with these issues by providing aid, accepting anyone who comes out of Syria as someone deserving of some form of aid or another, there has been mobilization of institutions to pay for education of the children, and people are receiving sometimes salaries as kind of a welfare. We see a kind of a story of a development of a humanitarian welfare states in the region, where people become very dependent on these on this aid and on all kinds of support. And this, I think also something like the Palestinian case in Lebanon, for example, where people have been in these refugee camps since mid of the 20th century. They're generation after generations of people who've been receiving, or their only kind of lifeline. One of the lifelines they have there is the UNRWA or the some of these aid organizations. So I think here I invoke the work of brilliant work of anthropologist Ilana Feldman, who really did an incredible study, Life Lived in Relief. Her book and her articles show really the dilemma of what does it mean to live and die under such a regime. That's not only just about aid, if they're going to be providing you aid, but what does it mean for someone and their offsprings, maybe 3 generations, to continue to live under humanitarian relief. So there's a lot of interesting questions that one needs to ask about the humanitarian structure and infrastructure, partly because we assume that they are just about, band-aids. We just go and try to save people or help people or do this and do that. But the realities are that people have been living under decades of under aid and under this kind of really, that it's not a state, but it's like an organization. It's a UN organization that's providing you with this. What does that mean, really, even to be a subject of a humanitarian relief? And I think these are important questions that needs to be thought through. One aspect has been the Palestinian predicament, but the other one is, Iraqi Syrians who continue to deal with these crises in the region, specifically now with the Syrian population. This issue is going to be very important to think with and to study, of course.
Thanks, Omar, and thanks, Jess, for that question. Beth Cassie asks, to what extent would you say wounds are transgenerational or intergenerational? Do you think children born today, someone just added a comment, so I lost my way, will also feel the wounds experienced by previous generations before them?
Yes, this is a great question. So I guess in the scientific literature, it has shown that children who probably grow up in certain war contexts might have also impaired development outcomes. So there is something that is not only in terms of the memory of trauma or the embodiment of that trauma, but it really, to take embodiment in a very literal way, your entire development system is shaped by these events. And this, of course, is explained by different kind of the science of epigenetics, where, because of environmental, social, emotional processes, certain triggers could actually switch your certain kind of elements in your genes, these triggers, these epigenetic triggers that induce a certain kind of pathology or something like that. So that's kind of, from at least medically, there is something really interesting to think about intergenerational trauma, how the environment and that ecology of war that you grow up in, or maybe shapes your existence, eventually ends up shaping also your biological and physical experience. In terms of more, the study that I kind of, the piece that I talked about a little bit about Beirut and this Iraqi refugee who was there, that was kind of a way of trying to think a little bit about these intergenerational traumas, not necessarily for this guy, but for many people he was dealing with, in terms of the Armenians, or in terms of the Lebanese, or in terms of the Palestinians who he encountered, that these encounters invoke these intergenerational trauma. These are conditions that people are living with. One famous kind of book that really deals very well with this story is the work of anthropologist Vincent Crapenzano, where he did an incredible study on the Harkis, the Algerian group who ended up in France, who actually fought with the French during the Algerian Independence War and ended up being kind of massacred in Algeria. But then France took them to the. They took them in back then, but then neglected that population for a really long time. So he looked at how the new generation of the Harkis have this incredible tensions and burst of anger and problems with their parents, who actually were refraining from talking about their involvement in Algeria and Syria. So there's this. So he really looks at this wound, and it's kind of one of the books that helped me to also think about the idea of the social and the intergenerational wound. He looked at how this history really metabolized in the present day. That history of the trauma, the tension with the family, really continued to articulate itself in the present moment, despite that this was really decades ago.
Thanks, Omar, and thank you, Beth. Solomon asks, do you think there are any lessons, figurative or otherwise, from the medical world in terms of healing wounds, that those working on questions of transitional justice and healing wounded societies could learn from?
Yeah, I struggle with that. I do struggle with kind of taking this metaphor of the wound also onto its all kind of biological. I mean, you know, I'm very reluctant from reducing it into just like a medical process and thinking about it in terms of just healing and injury and healing, and I do that. I do fall into that trap a lot, partly because I still am a physician and I do think like a physician. But that's a good question. I think, for example, when I read one of the pieces that I read that really captured this energy, this effervescence that I was talking about, was a piece by artist and writer Sundus Abdelhadi, who actually, that was her term, that Iraq is healing. That was the title of the piece that she wrote after the beginning of the uprising, and it's a wonderful piece that describes not only the incredible aspects of what's going on in Iraq back then, but also captures this energy of people like us in the diaspora who come to relate to what's going on there. So there was a nice kind of moment where we felt that we were kind of beginning to heal from this, you know, from the Iraq wound. So yes, I do think that this might be useful. I think the idea of the wound, I mean, I'm also not really inventing this. I need to say that, you know, many societies use the notion of the wound as a way to talk about injury. You know, it could be a wound, could be an insult. Someone insults you. That's you say you wounded me. You know, or it could be something that you've been carrying as part of your history. You know. Right now, with Black Lives Matter movement in the United States is exactly the embodiment of a historical wound that continues to shape this country here, and how it articulates all these grievances. So there is a lot to think with when we think about wound. I think people ask me several times, you know, what is a wound versus a scar? You know, we get into these technicalities. For me, wounds just capture a lot of these different processes that I'm trying to look at. In terms of in Iraq, for me, in addition to that material and social wound, the wound has a very symbolic place in the culture of different populations. First of all, poetry, you know, literature, as Bruce was mentioning, Frankenstein in Baghdad. These are all imaginaries and symbolic kind of treatments of that history, and it does deal with it through the notion of that wound. In Iraq, the people mention that Iraq is a wound all the time. When I was when I'm interviewing people, there was a lot of people use this analogy of the wound. With also, because of this revolution and specific kind of population that really the majority of which is from the Shia population of Iraq, the symbolic wounds of the Imam Hussein, for example, is and his death, and you know, this is something very much a part of the religious rituals and the commemoration of that event. This also is mediated and articulated through the wound. And actually, in these processions, people do wound themselves to remember that historical event. So there is a kind of an entry of this wound into it helps us as an entry into thinking about this. I'm also not trying to reify what the wound is. partly a literal thing that I analyze it, but also it's an analytic, it's a concept that allows me to look at a set of problems at the material, social, and symbolic registers of society, to think about what does it mean to be wounded? What does it mean to live through this kind of longue durée of conflicts and injuries? And what does it mean for a society to redefine its social relations around this problem of the wound? So that's kind of how I look at it.
Thanks, Omar. One of my former colleagues at the University of Edinburgh, Morteza Hashemi, he looks at blood donation and in the UK as a way of channeling the tributes to Imam Hussein and those wounds in a more productive way through blood donation. I'll turn to, is there a specificity to the nature of the Iraq War in terms of the nature of the
nosocomial infections? Yeah, I understand what that word is.
Thank you. I'm glad you do. Infections and multi-drug resistant affections in wounds.
Right.
Can you tell us what that means?
Yes, well, that's something it's very close to my heart to talk about. So I've written a recent piece called Iraqi Bacter, the pathologies and the pathologies of intervention. And this is part of one of the things that I did with the wound, and this is kind of part of the medical story. Maybe I didn't really talk about it, so thanks for bringing this up. When I was doing research in Beirut, one of the characteristics of these Iraqi patients that are coming in or wounded in Iraq and coming to seek healthcare in Beirut was that a lot of them had higher risk, and some of them were infected with the superbugs. And these are multi-drug resistant infections that we began to see more and more in the context of conflicts. And one of these infections was infection with a specific bacteria called Acinetobacter baumannii. And that bacteria is usually a kind of a benign bacteria, but when it becomes resistant to antibiotics, it attack or it kind of lingers in hospitals and begins to infect patients, and this is also this also is happening for many different reasons. One of the reasons is the kind of the failure of infection control in the hospital. So with the deterioration of the infrastructure in hospitals and the disruptions of the supplies, one sees a rise of these infections. So one hypothesis that I've been trying to work with when we saw this higher number of cases, sorry, just to kind of go back. And so the reporting of this virus, of this bacteria, started happening in 2003 by the US military. A lot of US military soldiers who were injured in Iraq began showing, infections. It revealed that they kind of got these infections from the field hospitals or from the injuries that they were subjected to. So it began being reported, and then the U.S. military called it Iraqi Bacter to refer to its relationship to the Iraq War. So I picked up on this story and tried to begin to investigate, what is Iraqi about Iraqi Bacter? Why, I know it's one way to critique it is to say this is a kind of a racist term. It's all of that. But then I really wanted to get deeper into understanding why do we see this suddenly in Iraq? Why do we see this suddenly in other conflict zones that are happening in Gaza or in Yemen or in Libya? And one of the two hypotheses that we had about this, one had to do with the sanctions, that over 12 years of economic sanctions in Iraq, and this comes from my own experience, the antibiotic supply or the use of antibiotic had been very chaotic. As a doctor, with all the other doctors, what we started doing to deal with rising infections of cases coming to the hospital in the 1990s is to bombard the patient with 3 antibiotics, with broad spectrum antibiotics. So an operation like removing your appendix does not require, for example, antibiotics unless it gets complicated. But in Iraq, any case that is doing this procedure, which is a very common procedure, you give the patient 3 antibiotics. So and of course, then you give 1 antibiotic, the next day that antibiotic disappears from the hospital. So you have to switch to another antibiotic. So there's a whole ecology of antibiotic use and disruptions of this that begins to create a problem in terms of infections. Because you're not giving the full dose, you're giving under quality antibiotics, you are disrupting the use of that creates the perfect environment for drug resistance to emerge. So that's was one hypothesis. Of course, it's very difficult to prove, but it is a very possible and plausible hypothesis. The second hypothesis that I worked with, and part of my research was not only just doing this work on my own, I worked with a kind of a large team also of scientists and scholars, from microbiologists to geneticists to clinical epidemiologists to historians of science to anthropologists. We all we had this big project of trying to understand the emergence of Acinetobacter baumannii in war conflict. And one of the other hypotheses that we had is that this bacteria has been driven by toxicity in the environment, namely the presence of heavy metals, contamination in soil and in water. And this is also an empirical study that needs to be done at some point. We actually tried to apply for a big grant from the Medical Research Council in the UK, but we were denied. We did another kind of a big application, and we're talking about $10 million applications for a big project like that, applied to the EU, one of the EU funding organizations, and also we were declined. So actually, a lot of that work was constantly being hit by maybe failure of finances, although some of it is being done underway as piecemeal research. But I think this is a very important problem, because over the next decades, antimicrobial resistance is going to be one of the main killers of human beings across the world. And increasingly, hospitals are going to become more and more toxic to treatment of patient, because this will be as soon as you enter the hospital, you'll have a higher risk of contracting a resistant antibiotics. And with failure of our present antibiotics to deal with this kind of problem, then we are dealing with a really, really long-term problem. So what my colleagues and I have been trying to really show and make visible is that war and conflicts had been driving a lot of these increases in infection that we're seeing in Iraq and in many conflict zones. And this eventually comes back to haunt haunt the perpetrator of a lot of that violence. And I think the kind of the movements of these, the whole story of Iraqi Bacter and its movement back to the U.S. with the injured soldiers back to American hospitals, and then infecting civilians and infecting people who have never seen a war zone, had been kind of an important red flag around this. So I think one of the ideas that this work is pushing is that war is not just about saving lives and protecting lives, and there is a kind of a clean war or a dirty war. All these wars are at the end changing the ecology of environments, and in the ecology here I mean by it the biological and the social, and eventually have these long-term impacts that globally will be will have to be reckoned with at some point. So this is one of the stories, that one of the things that is revealed in looking at these wounds is a microbiological environmental story about how bacteria and wounds are kind of interacting in places like Iraq and other places. And this is something that I've definitely been writing about, and something that will hopefully will be integrated in this broader study about wounds across that geography of the east of the Mediterranean.
Thanks, Omar. That is a powerful story of a circle coming back to, of a full circle effect. Mandy Turner says, fantastic talk. And she talks about Deborah Cowan's work. Deborah Cowan and others have also talked about the importance of the political economy aspect of circulation and logistics. Omar, you have already touched a little on this in terms of the impacts of sanctions on Iraqi healthcare, and you just did again, but could there possibly be a political economy of the wound too? How could we start thinking that through?
Yeah, very, very good question, Mandy, and hi. Yeah, I mean, I think the idea of a political economy of the wound is something what I've been trying to grapple with. This is what I'm looking at is how injury translates into broader. I mean, it opens up these broader political questions, political and economic questions around wounding, around seeking care, around movement, around how people manage this disruption of social and everyday life. So what really has helped me in thinking about this is taking the wound as my methodological approach. And so a political economy of the wound begins with paying more attention to this trajectory, what I call the trajectory of the wounds, and of the travels and the journeys of these wounds. Because through following the wound, you begin to see all these political and economic forces kind of coming together to define the experience of these individuals and communities. And of course, there is this is kind of on the micro level of this wound, but then you get into kind of a more of a institutional analysis. Then you begin to see how hospitals, healthcare systems are beginning to interact and deal with the flow of patients and probably the flow of the finances that come to deal with this idea. And then, as I previously mentioned, the whole Iraqi government was putting millions of dollars into this wound economy that just as a way to respond to this overburdening of injuries in the country. And then you get to a kind of a more global level, and we're talking here about the war machine, who's funding what kind of weaponry. Maybe the previous question that was asked about the kind of weaponry, the kind of logic that define these injuries, the kind of experimentation that go into this. The war in Syria, for example, I mean, it has to be traced to the movement of weaponry from the ex-Soviet Union countries back into a lot of what we see is the byproducts of the Cold War era, the movement of these weaponries and being sold into these conflict zones tell a kind of a long story and a political economic story, historical one, about the overproduction of these weaponry during the Cold War, and now they are being circulating back into other societies. I'm not necessarily trying to say all of this is happening because of this, but I'm saying that there are different processes where understanding or at least starting with the wound begins to open up all this kind of cascade of understanding and analytics to see the broader story. And that's kind of how I'm thinking about it in terms of defining a political economy and a therapeutic economy around the question of the wound.
Thanks, Omar, and thanks, Mandy. We have one last question from Larissa Fast, who helps bring things full circle to the start of our conversation. She says, a fascinating talk, and she wonders, Omar, if you could speak a little more about the interdisciplinary nature of your work, bridging humanities and science. How do you think that your medical training has influenced your approach to anthropological research and vice versa? Also related to Beth's question, Vamik Volkin's work on chosen trauma speaks to the intergenerational nature of trauma and how it perpetuates conflict.
I'll check this out. I don't know this work. Thank you so much for the reference. So one thing I find very common between a physician and an anthropologist is this attention to the patient, or the kind of, the subject that we're dealing with, and the immediacy of observation, the ability, like the idea that you really need to have very shrewd observation as both a participant observant or as a physician who, when the patient, one of the things that I was taught by one of my medical mentors is that I need to begin my diagnosis as soon as I see the patient coming through the door. It's not really just about examining and asking questions, but observation is very, very important. And I was also, one of my professors, Arthur Kleinman at Harvard, was also a physician and an anthropologist. And I also learned this, kind of realize how close being an anthropologist to being a physician. We're both kind of interested in this kind of empirical observations of the patients or of the body, and so there is a lot of overlap that I really enjoy thinking with. What I felt like in terms of what I brought in from medicine, not that it's just me who's done this, but I think my training in medicine had helped me to pay attention to the body proper, to pay attention to the biological processes, something that anthropologists in general over the past decades have kind of bracketed out. Partly from fears of thinking about biological markers as being, used to differentiate people, and so the obsession with social construction and with cultural construction had been more the norm in analysis in the social sciences. Medical anthropologists, of course, have had a much longer conversation on trying to really think about the body proper and think about the social body and the body politic, and how to integrate that has been, I guess, a challenge. And I feel like as a physician and anthropologist, my role is to be able to understand and synthesize all of this in my analysis. I can't really just take on something and just criticize the medical thing as this is what we're also trained in, is to undermine the medical discourses, and which is, it needs to be undermined when it's definitely doing something troubling. But I feel paying attention to the biological and the social, and this is why I use this term biosocial life of wound, is an attempt to really bridge these conversations. And there is no way that one could understand these phenomena without the other. So this has helped me to work in interdisciplinary teams, being able to at least move from the microbiological language into the historical. I find the work, for example, of historians of science like Hannah Landecker, who wrote a lot about what she calls the biology of history, which she defines as the registration of human activities, human activities over the past century and decades, in the genetic makeup of bacterial life. So what we see in terms of the antibiotic resistance is bacteria creating a defense mechanism to the things that we've been using, or to the antibiotics, to our own chemical weapons that we've been trying to use to kill this bacteria. So she brilliantly really shows you that over this centuries of industrialization and the mass use of antibiotics in human medicine and in animal farming, we've created a chemical milieu that has transformed the genetic makeup of bacteria. And that's a biology of history. So the biology of bacteria is shaped by historical activities. And this is, people have called this the Anthropocene in different kind of settings. So I feel what we need more of in general is more holistic thinking, more interdisciplinary thinking, and maybe even anti-disciplinary thinking. Maybe we need to be a little bit more knowledgeable, or be able to synthesize knowledge from all these different disciplines. So that's kind of how I look at it, and I feel like I'm moved more by problems rather than by disciplines. So I'm interested really to think about a social problem. And as a medical anthropologist, this is part of our history, is that we've been like an ethnography of certain problems have been like an early warning sign. We sometimes capture something that later on it turns out to be a major global problem, and this has been a kind of a story of I would say of medical anthropology, and what I like about this field, because of its intuition. Like, you're moved by this kind of intuition, and then the more you unearth the problems, the more you discover interesting connections and maybe even more problems. But being able to capture these processes in that kind of complex way begins really to highlight things that probably are invisible for the public health or the global health communities, and focusing on these questions, I feel, will have long term. I'm here anticipating, for example, that in the future of a lot of countries like Syria and Iraq, that the wounded will be a big social problem. Caring for people who are disabled will be a big problem in countries where you don't have even proper sometimes sidewalks for people to. I mean, when I went to Baghdad, the infrastructure of the street has not been changed since I left the country in the 1990s. So what does it mean really to inhabit even a space that is problematic for you to even move? These are maybe things that in more conflict-free places has been addressed, but in countries like Syria and in Iraq, they will be a major problem for any national or international body to really reckon with. And I feel like that's an important thing to imagine in the future. And of course, I think the idea of these wounds and the infections and the endemicity of these infections, when every hospital will have these, this is something, what does it mean when your hospital does not really even actually will increase the possibility of your death rather than of your cure.
Thank you, Omar. Omar, I'm going to invite you to turn on your gallery view, and I'm going to invite all the listeners to turn on their videos for one moment so that we can give a round of applause or add the clap emoticon. There we go. There are people there. Thank you, Omar, for this rich method and analytic of the wound and the challenge it presents of anti-disciplinary thinking. Thank you very much. You've inspired our work individually and I imagine collectively as well. Thank you.
Thank you so much for this invitation and for these amazing questions. Appreciate that.
Wonderful. Thanks, Omar. And thank you everyone for listening. That's it. Goodbye.
Bye. Thank you.
Thank you.